Good afternoon and welcome to everybody who's joined our webinar this afternoon. My name is Ian Pfeiffer and I'm very pleased to be here with Ingolv Urnes, who's Director and Co-founder of psHEALTH, and who's here to talk with us about referral management. I can see that there are a number of participants who've joined us this afternoon. From what I can see, we've got perhaps a combination of CCGs, people who are running referral management centers, and perhaps a number of prime contractors as well. So if, as we go along, if you've got any questions, please do feel free to just tap those in on the side of your screen, and part of my job will be to make sure that they're directed to Ingolv at the right moment. So without further ado, I'll hand over to Ingolv, who will walk us through the agenda and introduce us to the webinar.
That's great. Thank you, Ian. I guess what I wanted to talk through was quickly, what do we mean with referral management? Why is it being done? A bit about the process, a bit about the software that we have delivered, and try to do a quick demo, and then wrap up. And just as Ian said, I'm very keen that we get questions. So if there are any questions, please fire them off. In terms of what referral management is, I think there may be a little bit of a renaissance. It was interesting. I don't know if any of you have seen there's a recent tender out for cross-city CCG, looking at a large referral management solution. And I guess here it's described as a way of monitoring, directing, and appropriately managing patient referrals. And the aim is sort of twofold. What is the most clinically effective way, and what is the most cost-effective? How do you use the most cost-effective outcome? And then all that while respecting patient choice. So I think that's a pretty good way of thinking about what referral management is. In terms of the motivation for looking at installing a referral management center or running referral management facilitation services, as we know, these type of services have a number of different names, but fundamentally, this is about getting the right patient onto the right pathway. It can be used to improve patient choice, often used to ensure the take-up of local community services. There's often a problem in that CCG may have contracted a set of cost-effective community services, but it's hard to actually direct referrals into those services. Another big point is learning from referral data. It's quite amazing how how data rich this scene is, and how this data can be taken back, and how one can engage with the GPs, etc. The last 2 points are more in the financial arena. Is obviously how do we safely contain what seems almost unstoppable demand growth. And the last point, I guess, as CCGs are having to balance the books, the idea of understanding future invoices, if you like, based on referral volumes as of today, should allow for better financial control. So those are some of the reasons why people consider referral management services. I thought, and I sorry I had a question in the end, but I guess I thought maybe before we run through that, we just have a quick look at the process.
Okay.
As we all know, a typical referral process is typically kicked off by the GP, but it could obviously also be a C2C or consultant referral via email, on e-referral, or the old choose and book, or via fax. And then we get into typically step one, admin triage, where we're looking at, is this validating the patient, etc., etc. Some of these services have an element of clinical triage or peer review, and then finally booking, and then booking onwards, either out to the acute sector or indeed into out of hospital or community settings, and potentially back to the practice if the referral is not really appropriate.
So it's clear to me, just looking at your diagram, Ingolv, that the automation of complex and repetitive processes, which presumably comes largely under the admin triage part of your diagram, To what extent do you think the complexities of clinical triage can be automated?
No, look, I think that's a great question. I'd like to just to show you how we think about sort of this from a modular approach and from a software point of view, if you like.
Right.
So if you look at the software modules, the first one, I'll just take them in sequence, is the importing of patient data and validation. Okay, it's clear that at this point we're talking about really a lot of rekeying and sort of absolutely no work that's really not adding any value. And I think, as you said, that's high volume, it's time consuming, but
repetitive, manual.
Exactly, but easy, very easy to automate. And as a matter of fact, in the demo, I'll show you a bit how that works.
And presumably also, because it's manual, prone to errors.
Yeah, no, that's exactly right. There's a last point in this, is that not only is it's manual and repetitive, but it's also quite hard to recruit people to do that work.
Sure.
Because it's a little bit of a thankless job. Second block here in the module is capturing the referral reason. So once again, with using a good rule set, once again, this can also be done to a great extent in terms of done manually. The next box, so the application of referral policies is harder, and this is where the question of how far clinical triage can be automated is tougher. And I guess what we're finding is that there are certain areas within MSK, say, that are quite standard, quite straightforward, that lend themselves well to automation. And then there is a good spread of referrals that are much, much harder to automate. And I guess referral management center or referral facilitation centers take different processes here. You could go and do, in essence, sort of set up rules that says I'm only going to be peer reviewing every 10th referral. I've seen areas where actually the referring clinicians can tick whether they want a case to be referred, be triaged. So what the software can do here is really apply these rules to the referral, as opposed to relying on manual judgment.
So then there are a couple of elements then. So it looks like the earlier elements, this is largely the inclusion-exclusion type rules, and then later on some mapping into the system which will be manually reviewed and which we might be able to learn from. Perhaps we'll move on to that.
No, I think you're right. There is at the core of this is a set of rules. And of course, as we capture the data with, say, a manual confirmation at the end, we can then understand the efficacy of the individual rules.
Learning from that.
Exactly.
The accuracy.
That's exactly. And that's what we're hoping to do. Just want to touch on the fourth box here in terms of pathway options. Obviously, what we're doing here is really sort of intelligent shortlisting. So what we could say, here are the 5 possible pathways, or here are the 5 possible providers for this particular service. But what's exciting here is you can use our rules engine to overlay regional preferences, so this is where you can ensure that you bump, for example, a community service up the pecking order, so to say. So that's kind of conceptually how the software solution works. So maybe what we try to do now is go through and just show you a little bit of what this looks like. And see if we can find it. So what you got here is a sort of standard referral letter. So this is Frank Johnson, who's gone to his GP. This is a letter that's written by Kevin James, and it just shows. So this is in essence unstructured letter suggesting that this individual needs an audiometry test or is referred for a hearing test.
So unstructured in the sense that the system isn't going to predict the structure that it's going to come in when it's received.
Yes. So, well, unstructured really also means that we're just looking at interpreting text as it arrives.
Okay.
So the benefit of that is we don't have to, on the first go, ask the GP community to change their behavior.
Or provide them with templates.
Exactly. And I'll come and talk about templates in a second.
Okay.
So what we're doing now is we're in essence sending the referral letter into the triage engine. Now, whether this came via Choose a Book or ERS or elsewhere, it doesn't really matter. Where we're now inside the psHEALTH system, so we're just showing that this particular email has arrived this particular referral has arrived by email from the Norton surgery. And what we can see here is, I guess this seems maybe trivial, but what the computer has done is taken that unstructured letter, in essence, and taken off all the parameters that we need. So is it routine? Who's referring clinician, etc., etc. So there's no need for rekeying of any sort. And then at the bottom we got a copy of the letter. Now what we're doing is we're sending the letter. We've sort of torn the letter apart, if you like, and categorized it. So we now know the referral reason. We're sending that through the triage engine, and it will go in and say, okay, what are the appropriate providers for this particular referral? And it will just take a second. And what we should see now is that, in essence, the system is recommending an approach. So for hearing test, in this case, it says we should be going to Newcastle Street, and what it does, I'm just showing you the letter here again, that in essence the machine got it right, if you like.
Okay.
There's also the option here to say, as an operator, I don't think this is the right decision. So this is when we talked about the rules and the ability to measure the efficacy of the rules. Of course, we can then go in and see how often are these rules found not to be working.
So for these more complex parts of the process, then what you might find is that for each referral, someone might manually go in, review the decision that the computer has come to, and then if there are any changes, you can measure where the system's going wrong, and then you can learn from that and develop your process. And presumably also, from a process perspective, what you're seeing are the pinch points, the inefficiencies.
Yeah, no, that's spot on, and this is why this is so exciting to be working with, across multiple health regions, because obviously the learnings are very significant. So I wanted to go back and show you the just a quick what this process does, and what's so exciting about this process is that we generate an enormous amount of management information. So I just wanted to so here are some stats on clinical variation. Now this is between various health economies, and it shows that you walk into your GP surgery, the likelihood of being referred for varicose veins varies by a factor of 7. So the issue of variation is not a trivial one.
No, and so what we're seeing here is the variation between different health economies. And what sort of variation would we see within, say, a practice?
Yeah, no, that's a very good question. We see if I can get to the next page here. Here we're looking at managing variations, just looking at it all the way down to GP level. And I guess what this shows, if you look at, so this is ranking GPs by how much do they refer per session of work. So the 50th percentile, so the average GP, if you like, will make a little bit less than 1 referral per session, whereas down at the 20, savvy, well-trained GP will make as little as 0.5 or 0.6 referrals. But I guess the point is here that this varies quite dramatically. It's only really with data and taking this data back into the GP community and having discussions, you could sort of improve the quality and make sure that all the participants in the system are learning from it.
Yeah. We've had one question come through, and I don't want to jump ahead or anything, but I think it's a good question, and that's the King's Fund came out with some health warnings about referral management some 5 years ago. Perhaps as we're looking at analytics, it might be a good moment to think about it. What's happened since then?
Well, I think that I guess what the King's Fund did was, firstly, there was a challenge about whether referral management centers deliver value for money, and I think they're absolutely right to challenge that. And I think that the findings were that there were certainly evidence of cases where it did not deliver value, but I think there was also evidence of places where it did deliver value. One of the conclusions was that the involvement of the GP environment, using the data, going back and changing behavior was absolutely critical.
Hmm.
I guess what I feel has changed.
Is that not happening very much?
I think this is sort of evolving, right?
Yeah.
So I don't, going back probably wasn't as much, but it probably still isn't done well enough up and down the country.
Do you think that's because GPs actually find it difficult to access the information, or the way it's presented back to them, or is other attitudes?
Well, I think that the biggest question, the biggest challenge is really that there is relatively little credible referral management data around.
Okay.
So most of that referral management discussion has been done on sub-data, which is 2 to 4 months out of date. It was really collected for a different purpose, for the purpose of invoicing. So I think that's the quality of that engagement process. Yeah, but that to me, that quality of the engagement process is critical in terms of being successful at this. I think the last point I'd say on as regards to the King's Fund is that obviously what I've shown you today is quite significant automation of the process. And the King's Fund rightly said, if you're going to be running this and it's going to cost you, £20 per referral to review, then this may not be value for money.
Yeah.
I guess if you're looking at doing it at 20, 30, 40% of that, then obviously this becomes a very different game. Does that make sense?
Yes, it does. Thank you.
That's great. I think I was just thinking, Ian, just to sort of wrap up with some of the challenges and then end on some more talk about the kind of the business case.
Sure.
So I guess as we at psHEALTH see this, the challenges, and this is particularly for commissioners, equally relevant, I guess, for prime contractors and ACOs, is this idea that running the business, so to say, or running the organization really with a rear view mirror is not great. And we believe real-time data is really how we're solving that problem. We talked about poor data, and what we're about is collecting really good information on actual referrals, not sus data, not data that's old. And as I said, the last point is really that we have these processes. I've seen a few referral management centers with just very, very labor-intense processes, which obviously is expensive and can also delay the actual referral of the patient onwards. So what we believe with is that by software can help you automate large part of that, and also help you enforce, if you like, a much more consistent process. So those are a couple of as we see the challenges we feel that working with software, a software solution like ours can be helpful. Perfect. Just looking at the I think.
Have I missed any questions?
I
don't want to miss out on anything.
Yeah, I think. Well, we'll see. There's one question here about the business case. Does it really save money? And I guess the business case is quite hard. So if you're a CCG running an existing referral management center, that's kind of one strand of business case. Then you've got a CCG without an existing referral management center, and then obviously you have a number of providers and prime contractors. So I guess for this bit, we've tried to set this out and say, okay, there is at an admin triage, clinical triage, and booking level, we think across that whole process, we should be looking at taking out 40 to 80% of the people that does that. Now, if you have so typically we will achieve very, very high automation around admin triage, okay, significantly lower around clinical triage.
Yeah.
And once again, the booking depends a bit on what process you use. So I would say that some of these processes are sort of automated from 80-90% to just 20%, depending on the configuration of your particular service. The other question is around what does this mean for a CCG in terms of what do we get in terms of reduction in activity levels, pathway selection, benefits, etc., etc. And look, this is really, really hard. There are a number of data points out there in terms of reducing activity levels by 4, 5, 6%, which may actually be quite good because most CCGs are running into an area where they're actually facing increases in underlying demand. So being able to curtail that or even reduce it slightly is very, very valuable in its own right. I guess the other we've seen is reduction in the referral for procedures of limited clinical value. So I saw one CCG spending, I don't know, £3 or £4 million on those procedures, going to £2 million. So the way we think about this is we should be really, when we work with customers, we're really saying, one should be targeting net cost savings, certainly of £1 million, but the numbers can quickly become much bigger than that. So, and we talk about cost savings here, we're obviously talking net of running referral management, et cetera, et cetera. So I think, there's one question maybe before the two questions here before we sort of wrap up. That's the one on Choose a Book and ERS,
okay, yes, taking us back slightly, yeah.
Yeah. So I guess the issue here, Ian, is as you know, we moved from Choose a Book to ERS just in the summer, which the move was a little bit tricky, but it wasn't a smooth one. But I guess we've tried to design our systems so that they can work with ERS or standalone. So whether you email, flexibility. Yeah, exactly. So whether you email it to us or whether we collect it from Choose a Book, it sort of makes no real difference. Obviously, we believe in the future that ERS makes a lot of sense, and we're sort of working with HSCIC to find ways of increasing uptake, because I think a single funnel is going to make it easier for everyone, all the participants, and that's also sort of supporting the government in their sort of paperless initiative. Gosh, what have we got in terms of time?
So, eyes on the clock. Okay, we have a few more minutes perhaps. So I just want to pick up something that we were discussing earlier on, Ingolv, in terms of the use of templates, because what we saw in the demo was kind of an unstructured letter that might come in. Presumably there are difficulties when you have an unstructured letter in terms of exactly how much automation can take place. But if you can move on to a template, presumably you can move that much further forward with automation.
Yeah, look, this is a great question, and no doubt we are sort of attacking this problem from both ends, if you like, with either running referral management on already established templates has a significant impact on the improved automation rate, as we call it. But you sort of have to have a solution that can cater for everyone. So the worst, if you like, is the unstructured letter. The best is the very highly templated, down to for NSK have a subset of templates. The exciting bit about that templating, of course, is you can write very, very specific rules. So now you're really coming into the area of very, very, very significantly reducing clinical triage. And I guess looking out 2 to 4 years, I think CCGs around the country are pushing the introduction of templates.
Yeah.
I think most GPs actually, once they get used to it, the user experience that I've seen is pretty good. Is happy to use it. So I guess what we feel we're helping CCGs in that process is, of course, we can also immediately, when we pick up a referral, we can establish what template was it on on the right version, and helping, in essence, make sure that the system operates with the right templates.
Yes, yes. And I'm conscious of time, but I do just want to slip in one more question, which is, I know psHEALTH has a lot of experience of joining systems together, but could you just touch perhaps on how some of this stuff links with integrated care?
Yeah, I think I guess it appears that the sort of the accountable care organization is going to be an important part of the health economy of the future, and of course, whilst we don't get, I guess, our principal role, whether you call it referral management or whether you're operating or managing a single point of access, but the ability to, in essence, take in referrals, send or signpost in the right direction, and collect the data on that, we think is critical. So we've got 1 or 2 instances where we are working with prime contractors, delivering that, doing our piece, if you like, to the integrated care.
Yeah. Fantastic. All right. Well, that's unfortunately brought us to the end of a very interesting conversation, and been a great deal of food for thought. I think it just leaves us to say thank you for joining the talk. We will put this discussion up on the website, www.pshealth.co.uk. For any further information that you might like to get, or if you want to inquire further into what we do and the way we think about things, you can get in touch with emma.walker@pshealth.co.uk, and the telephone number on the screen, 08450 50 5120. Ingolv, thank you very much for talking to us. It's been, as I say, an illuminating talk. Thank you again to those of you who've joined us, and we hope to see you next time.